Um, On behalf of IIP Central Delhi City Branch and BLK Center for Child Health, I, Dr. Swati Bharadwaj, welcome you all to this webinar. As we all know, in the last decade, there have been significant advancements in the field of genetics, and genetic testing is more freely and easily available with a very short turnaround time. However, for us clinicians, it is often difficult to decide which test to order and, more importantly, how to best interpret the huge amount of data which comes from the results of the test. So, make things simpler for us. This today's webinar's topic is genetic testing, which test and when. To chair the session, we have with us Dr. Anil Handoo. Sir is Principal Director and Head of the Department Laboratory Services at BLK-Max Super Speciality Hospital. Welcome, sir. And Dr. Hemlata Bhatia. Ma'am is Senior Consultant Medical Genetics at Max Hospital, Shalimar, Bagh. Welcome, ma'am. I request Dr. Hemlata to introduce our speaker for today, and we can go ahead with the webinar.
So thank you, Dr. Swati, for introducing me. And so Dr. Ranjana, is everyone knows Dr. Ranjana, and she is not new to the world of medical genetics. She's a senior consultant in clinical genetics at Yashoda Hospital, Ghaziabad, Seeds of Innocence IVF Center and Gene String Lab, and she's a visiting consultant at BLK-Max Hospital. She's a recipient of intramural grant from Gangaram Hospital for conducting research on genetic factors in early onset fetal growth restriction. She is also an ex-coordinator for the NEET program for newborn screening and ex-in charge of thalassemia screening and prevention program run by the Delhi government. And she has had more than 20 publications to her credit in the world. So welcome, Dr. Ranjana, and we look forward to listening to you on this tricky topic.
Thank you, ma'am, for the kind introduction. I'll share my screen. So, is my screen visible?
Yeah.
Yes, Dr.
Okay, as Dr. Swati has said, that genetic testing has become easily available, something like over-the-counter testing. So how do we go about it? It is complex indeed. How to optimally advise a genetic test? What would be the ideal situations? And to maximize the yield of your genetic testing in the interest of your patient. So, as we go through our learning objectives would be to understand the principle of these genetic tests, where to use them and how to interpret them, and the limitations which are associated with these tests. So, I will be talking, although there are a number of tests which we do, which are commercially available, the genetic tests, but here I'll be touching mainly on those tests which are relevant in a pediatric practice. So various DNA-based tests which we commonly order in our clinics, they are Sanger sequencing, next generation sequencing, which includes the disease panels like myopathy panel, epilepsy panel, or genodermatosis panel, a clinical exome sequencing, a whole exome sequencing, or a whole genome sequencing, which all come under the heading of next generation sequencing. Next generation sequencing is the testing methodology. And next in this list would be a chromosomal microarray, which looks at the chromosomes in a more zoomed way. Then there are some targeted tests, where you have to know what you are looking for. So these include the FISH, the fluorescent in situ hybridization test, and various PCR-based tests. So let's see what are there in the untargeted. I would like to just emphasize on these words, the untargeted and the targeted tests. Many a times we are ordering the tests, but we don't know what exactly we are looking for. So if we don't know the exact region to look for, we go for the untargeted test, which includes the next generation sequencing, which the various panels I have enumerated, and the chromosomal microarray, they all come under the untargeted testing umbrella. The targeted tests, they include the polymerase chain reactions, which further they include, there are various types of PCR-based tests, which include the Sanger sequencing, qPCR, QFPCR, triplet primer PCR, then multiplex PCR, the MLPA, and the FISH. They are all targeted tests. So here, whenever you're ordering these tests, you have to know the exact mutation, the location, or the variation, which the area where which you want to be targeted. So let's see. Let's go back to our basic biology. What the DNA looks like. So we all human beings, every cell is composed of 23 pairs of chromosome. A chromosome is basically a 3D structure which has the DNA, a double helix structure, which is tightly coiled in this chromosome, and there are two complementary strands, which constitutes of the four nucleotides, the adenine, thymine, cytosine, and guanine, which are complementary arranged on both the strands. What are the types of genetic disorders which we see commonly? We can classify them into chromosomal disorders, the single gene disorders, the multifactorial, and the polygenic disorders. So the chromosomal disorders we commonly see are Down syndrome, Turner syndrome, DJOR syndrome, which we must have all encountered sometime or the other in our clinical practice. Single gene disorders like thalassemia, neurofibromatosis, Duchenne muscular dystrophy, to name a few common ones, and spinal muscular atrophy. Then there are multifactorial disorders. I've not enumerated. So there are multifactorial disorders are the ones where there is involvement of genetic loci, but the environment is also playing a role. So these disorders, they include the CTEV, the cleft lip palate, pyloric stenosis. So there is definitely a underlying genetic component, although a weak one, but it does get influenced by the surrounding environment. Then there are polygenic disorders, which will include the stature of the individual, the skin color, hair pigmentation, and so on. So we in our day-to-day practice, we see more of the chromosomal and the single gene disorders, and this will be my basic the basis of my discussion today. So let's first take polymerase chain reaction. What is a PCR? A PCR is a process which rapidly amplifies millions to billions of copies of a specific segment of DNA, which can then be studied in a greater detail. We use short synthetic DNA fragments, which are called primers. They are designed to select the segment of the genome to be amplified by multiple rounds of DNA synthesis. So we have PCR machines, and we use some more elements in this PCR machine, including the primers, which are targeted for a specific region, a region of interest, to amplify that region. And if we can broadly classify the types of PCR, it includes an endpoint PCR, which is usually qualitative to semi-quantitative in nature. It is used to determine the presence or absence of a target in a sample. More commonly, we use the quantitative PCRs, where we do analysis of the copy number variation, the genotyping, or pathogen detection and quantification in a quantitative PCR. So, what are the types of quantitative PCR which we commonly use? Number one is fluorescently labeled quantitative PCR, which is also called QF PCR. This is commonly used in a prenatal setting where we test the prenatal sample for aneuploidy. Next is the multiplex ligation dependent probe amplification, also known as MLPA, which checks for small deletions and duplications. Like this is most commonly used in Duchenne muscular dystrophy and spinal muscular atrophy. This technology can also check for methylation abnormalities, where it is known as MSMLP, methylation specific MLP. This test is done commonly for Prader-Willi syndrome and Beckwith-Widman syndrome, Angelman syndrome, and Silver-Russell syndrome. Then we have real-time PCR, which we use for quantification of viral loads or quantitative analysis of gene expression. Quantitative analysis of gene expression is more commonly done in a research setting rather than in a diagnostic setting. Then for CNV validation, what is a CNV? It is a CNV is a copy number variation. It is a small segment of chromosome which has been either there is a deletion or a duplication. This is known as a copy number variation. So any technology which has detected a multiplex technology which has detected a CNV, it has to be validated by an orthogonal method. So we commonly use quantitative PCR to validate that deletion or duplication. One can also do a targeted SNP analysis by this method. Then comes the triplet primed PCR. This is done to check for the triplet repeat expansion disorders, even the penta repeat, any nucleotide repeat disorders like fragile legs, Huntington disease, spinocerebellar ataxia, so on. So let's see what is Sanger sequencing. So this is a method for determining the nucleotide sequence of a segment of DNA. So a DNA is a double-stranded structure. It is denatured into single-stranded by structure by heat method, and we use specific primers. The PCR product which we get, we use special types of DNTPs and DDNTPs, and this is passed through a capillary electrophoresis, and a graph is generated, which is known as a chromatogram, which shows the sequence of the nucleotides. So in a Sanger sequencing, we are actually sequencing the gene exon by exon. And you can realize how tedious it can be, because sometimes the genes can be very big, constituting of many exons, and we have to take one exon at a time to sequence the whole gene. So where do we use Sanger sequencing? Firstly, it can be used wherever there is only a single mutation associated with that disorder. So the prerequisites here would be that the disease shows genetic homogeneity at a variant level. So that means there is only one variant associated with that disorder. One or few variants. Mostly it is usually one only, and you have definitive clinical features or diagnostic tests for that particular disorder. Like in sickle cell anemia, there's only one mutation. We all know there's only one mutation where glutamine is at position 6 is replaced by this is the amino acid position 6, where glutamine is replaced by valine, or in achondroplasia, where the most common mutation is at C dot position 1138, where G is replaced by A. Similarly in Eppert syndrome. So these are few examples where we have only one mutation to check for. Whenever we are suspecting, we all know, whenever we are suspecting sickle cell anemia, we don't have to do any other bigger testing. We can directly go for this one mutation which is associated with sickle cell disease. So this is just a chart to tell you that how these three disorders which I have just enumerated, they have one specific diagnostic test. In sickle cell anemia, you have hemoglobin electrophoresis, which gives you the sickle peak. In achondroplasia, you have typical clinical features and X-ray findings. In Eppert syndrome also, you have the typical clinical features and X-ray findings, consisting of you have mittened hands and craniosynostosis in Eppert syndrome. So you can easily do a Sanger sequencing in these situations rather than going for bigger, fancier tests, and this will be more cost effective. So that was one example. The other example where you can go for Sanger sequencing, where the gene involved in with that phenotype is a small gene. So small gene means that you have less number of exons. You have a definitive functional assay to validate your phenotype, and there is genetic homogeneity. That means that disorder is associated with only one gene. There is no other gene associated with that particular phenotype. So the typical example over here is a case of beta thalassemia, where the associated causative gene is the HBB gene, which has only 3 exons. And the definitive functional assay which you see whenever you get capillary electrophoresis or HPLC of hemoglobin done, you'll find increased HbF, the fetal hemoglobin fraction, and you have the typical clinical features also of thalassemia major. So all patients with beta thalassemia will have mutations in HBB gene only. You don't have any other gene involved with beta thalassemia. So this is one case, and the third, the commonly used Sanger sequencing application is in a prenatal setting where you're doing a prenatal diagnosis. So I have taken an example of beta thalassemia over here. This pedigree shows a high-risk couple where the husband and wife both are carriers for beta thalassemia. They have an affected 4-year-old son, and there is a second ongoing pregnancy which is at 12 weeks. They have come for prenatal diagnosis. So here you will check the affected child first, the 4-year-old boy. You do a beta globin gene, that is the HBB gene sequencing. All sequencing methodologies, they are to be compared by the reference sequence, the reference genome sequence. So on the left side, you have the normal sequence. On the right side, you have the patient sequence. Now this boy has been found to be homozygous for one of the common mutations for beta thalassemia. And the mother underwent a prenatal diagnosis by amniocentesis at 16 weeks, and the fetus was found to be the fetus. This is the sequence, the chromatogram of the DNA extracted from the amniotic fluid, which shows the fetus to be homozygous for the same variant which was detected in the elder sibling. That means this baby is likely to be affected. So the parents are counseled and about the likely outcome of this pregnancy, and if they wish, they can choose to discontinue this pregnancy. However, this is a very useful technique, but it does have some limitations. It is not commonly recommended in patients with unknown genetic disease. Or if the disease which you are suspecting, it has the gene involved is a large one, like in Marfan syndrome, the fibrillin gene, the FBN1 gene is a pretty large genes. Also, it is not to be prescribed in patients with a phenotype that can be caused by mutations in several genes. That is, there is genetic heterogeneity, like cardiomyopathy, like muscular dystrophy. There are many genes which are involved with these phenotypes. Also, for doing Sanger sequencing, you have to know they have to have a prior knowledge of the genome. The Sanger sequencing methodology can only sequence a limited size of the genome. It is costly, it is labor intensive for large sequencing. So what will be the way out for this limitation? The answer is next generation sequencing, which has come in a big way now, and a number of panels and are available which can be done by this sequencing methodology, which is called next generation sequencing. Now, next generation sequencing, it refers to all post-Sanger sequencing technologies that enable massive sequencing of the DNA. So massive means millions of DNA fragments are sequenced in one go. These are certain terminologies which are associated with NGS. So this sequencing is parallel also. That means multiple fragments are sequenced simultaneously. It is deep. That means each fragment is sequenced a number of times. And there is a process called alignment where the generated sequence is aligned to a reference genome. I have already mentioned this, that whenever you're sequencing your DNA, you have to align it with a reference genome. So we have those reference assemblies where we align the against which our sequence is aligned to look for any variation and detect the mutation. So this is just an overview of the next generation sequencing workflow. First of all, the DNA is extracted. A library is prepared with you attach some adapters and it is like barcoding of the DNA fragments. Then the sequencing is done. This is a Lamina sequencer where on your lower left side, and the chromatogram which is generated, it is analyzed. It is now comes the role of bioinformatics. It's a complex process. Millions and millions of data is generated, and through bioinformatic pipeline, and the analysis and variant calling is done. And just to give you an idea of the downstream analysis, how it is done of all the variants which are detected. So at the outset, you may have let's say millions, billions of variants. So you go stepwise. Although this is all incorporated in the pipeline itself, but what are those steps for filtration? So you take gene-based annotation. That means you see which would be the strong variants. We know that the splicing variants are the strong ones. So you take those, you filter based on uh, those criteria. Then you remove the synonymous and non-conserved variants. Then you remove the high frequency variations in the population databases, like the 1000 genome database, NORM-AD, and all those. Then you remove variants in dispensable genes, and you do a phenotype-based filtering. And lastly, once you get one or two variants, which would be your variant of interest, you can do the checking, or this is called genotyping in other family members. So suppose you get a variant which has already been reported in literature, which is well validated, it is a well-known, then your job is easy. Then you may not, go about checking in other databases, or maybe in other family members. The whole problem comes when it's a novel variant, and then the classification of the variant also becomes a little tricky. So I'll just touch upon what are these NGS-based genetic tests. There's something called whole genome sequencing. So we all know that the DNA has exons. A gene will have an exons and introns. The exons would be the coding regions, and introns would be the non-coding regions. So if you're doing a whole genome sequencing, it will cover the entire genome, which will include the exons as well as the introns of all the genes. If you're doing a whole exome sequencing, the coverage is restricted to the exons only. That is the coding regions only. The introns will not be included. And there's something called clinical exome also, which we do write. And this clinical exome, what it does, it covers exons of only, say, around 6,000 to 8,000 genes, which are reported in the OMIM database. We all know that OMIM is a database which enlists the genes, the disease-causing genes, the pathogenic disease-causing genes only. So clinical exome is covering only those genes. Then we have disease-specific panels, which usually has, say, about 50 to 200 genes, which will be specific to the phenotype, like deafness, retinitis pigmentosa, hereditary cancer, and so on. And they just to familiarize you to a term called trio sequencing, where we do the checking of the proband, which is the affected person, along with the parents. So this always helps, like you have just seen how complex the bioinformatics part is, the filtration and the variant calling part is. So once you do a trio sequencing, it does make your job easy, because the variant filtration becomes a little less tedious. If you're looking for a de novo variant, it will not be there in the parents. If you're looking at an autosomal recessive disease, then you have to see which gene the parents are carriers for, which significant genes. So this is how a trio sequencing gives a better yield. And this is to tell you how do these three sequencing technologies, they compare with each other. So genome, if you talk of coverage, I've already talked that in the genome sequencing, all genes and non-coding DNA is also covered. In exome sequencing, it's only it's the entire exome, which includes 20 to 25,000 genes, whereas in a targeted gene panel, it would be around 10 to 500. The accuracy in a genome sequencing is little low, whereas it is very high in a targeted panel. The time taken to run these tests is longest in a genome sequencing test, and it is rapid in a targeted panel. Of course, a genome sequencing is most expensive, and a targeted panel would be most cost effective. There's something called depth. in these sequencing technology, which I've already talked about, the depth means how many times a particular variant is sequenced. So a depth is little on the lower side in a genome sequencing, whereas it is very high in a target. If you're doing a targeted gene panel, it is more than 500x. That means that particular variant, a particular position would be covered more than 500 times if you're ordering a targeted gene panel. And the confidence of variant calling will be very high, although there would be limitations of so that means a targeted gene panel would be more cost effective. But the limitation is that suppose if you have ordered let's say you ordered a myopathy panel, and we all know that with each passing day, some or the other new gene is being discovered, which is being attributed to a particular disease. So if your panel is not updated, you may miss the causative gene if you're ordering a targeted panel. So you have to see the total, the whole scenario, and what are the how budget friendly your patient's pocket is, what kind of disorder you're looking at, and so on. So we'll see what are the challenges we face when we are ordering these tests. So this is one case, a very simple one, where from this pedigree also you can make out this was a 2-year-old boy who had visited. The mother was pregnant. There was an early ongoing pregnancy at around 12 weeks. So this boy had multiple cafe lip patches and some mild limb asymmetry also in the lower limbs. The father was also affected. He had multiple skin pigmentary lesions and nodules. So it was a very straightforward diagnosis of neurofibromatosis type 1. The important point over here is that you cannot do a prenatal diagnosis although the clinical diagnosis was very clear, but a prenatal diagnosis, to proceed with that, you need to do the molecular testing. So now which genetic test you would order in this particular situation? We know that neurofibromatosis type 1 is caused by mutation in the NF1 gene. That means there is no genetic heterogeneity. But if you remember, if you can recall the points which we had discussed for taking these tests, like Sanger sequencing, clinical exome, or whole exome, which one? So we know that for Sanger sequencing, the gene needs to be a small one, or at least 1 or 2 variants only should be associated with the disorder. But here the NF1 gene is a pretty big gene. It has 58 coding exons. It is around 12.3 kb long. So sequencing by Sanger method would be very labor intensive. Yes, clinical exome and whole exome, one can order. NF1 gene is covered in both the tests. Although clinical exome sequencing would be more cost effective, because we know that this is covered also, and the cost will be also slightly on the lower side if we compare it with the whole exome. So this is the result which we got, and a pathogenic heterozygous mutation was identified in the NF1 gene. The prenatal testing was done by the targeted mutation testing. We did a Sanger sequencing for doing the prenatal diagnosis after doing the amniocentesis and taking out the DNA from the amniotic fluid. So the American College of Medical Genetics and Genomics, they use they classify the variant. It's a tiered classification into 5 types. And they use 28, there are 28 evidences which are used to classify these. By application of these evidences, the one can classify these variants as pathogenic, likely pathogenic, variant of uncertain significance, likely benign variant, and benign variant. Although this ACMG classification was developed in 2015, and it is undergoing an overhaul and will be soon having another set of criteria to classify these variants. But for the time being, we are doing it this way. The important point over here is that any variant of uncertain significance is not to be taken as confirmatory, and it should not be taken up for prenatal testing at all. So this is another case. Now, this is a complex, I would not say a complex pedigree. You can easily, I'll try to take a pointer over here. Okay, so if you can all appreciate the arrow over here, this is the person, a 45-year-old male. This is an adult case which I'm describing over here, but there is a message which I just wanted to for you all to take. That is why I have brought this case. Now, this 45-year-old male had come with unsteady gait, slurring of speech, loss of appetite, and constipation. He had no history of cognitive decline, and on examination, this person was non-ambulatory. He was wheelchair bound. There was a lot of restlessness, and he had slurred speech, hand tremors. Cognition was pretty preserved. He had brought a MRI brain also with him, and which showed cerebellar and brainstem atrophy. On taking a detailed family history, what I found was that he had a younger sibling, a young brother who was also similarly affected, and his mother, who was deceased, she was also affected. She passed away at 55 years of age. One of the maternal uncle who is alive, he is 50 years old now. He is also affected in the same way. This uncle has three children, one daughter, one son who is normal, and two daughters, 22 years and 20 years, who also had the same problem, who also have the same problem. And this couple, this man has a son and a daughter, a 12-year-old daughter, who was severely affected. So, based on the clinical examination, the history, it was there was a probable diagnosis of spinocerebellar atrophy. So, this is a trinucleotide repeat disorder, and if on taking a detailed history about the the daughter, who was severely affected, she was almost bedridden, and although she was 12 years at the time of presentation, but around 5-6 years back, she had visited another hospital, a multi-speciality hospital, a government institute rather. She had presented with motor regression, progressive atraxia, dysarthria, and oculomotor apraxia. So after a detailed workup and management, the doctors there had sent a whole exome sequencing, which turned out to be negative. And when I asked this man to undergo genetic testing, I talked to him, I counseled him about the likely disorder. I asked him to undergo genetic testing. He said, my daughter's report is negative, and I don't think we have a genetic disorder, in spite of all this elaborate family history, significant family history. And I was surprised to find that it was a whole exome sequencing. Of course, it could not be detected by a next NGS-based technology. A whole exome sequencing cannot detect a nucleotide repeat disorder. So I have already mentioned that you have to do it by a PCR-based method, which is a TP-PCR. And we sent out a spinocerebellar ataxia panel, which is done by a TP-PCR technology, and the underlying disorder was confirmed. It was a SCA2, which was confirmed in this man. And also the important, another interesting thing over here in this pedigree was the phenomena of anticipation, anticipation means that anticipation is the phenomena which we see in nucleotide repeat disorders like Huntington disease, spinocerebellar ataxia, fragile legs, where we find that the successive generations are affected at a younger age as compared to the previous generation. So it's very evident in this pedigree that the older generation, they were affected in their 40s or 50s, whereas in the younger generation, we can see that these two girls, they were affected in their second decade, in the third decade, whereas the youngest one now, In fact, I just recently got the news of this girl having passed away also a few days back. So this one was so severely affected. She was affected in early childhood itself. So this is how we get to recognize the disorder from the pedigree also, apart from the clinical examination and the ancillary testing. Now this is my last case, which I had seen in BLK-Max itself. So this was a 3.5-year-old boy who was operated in the pediatric surgery department for GERD, and he had presented with a global developmental delay, where the motor delay was much more than the cognitive and the speech delay. The child had myopathic faces, which included ptosis, tented upper lip, downturned corners of mouth, a high arched palate, had flail chest, there were eczematous patches, poor muscle mass, and multiple joint contractures, and there was a significant laxity and bilateral wrist joints. Antenatal history, there was a history of polyhydramnios, and the child was also found to have bilateral CTV and hip dislocation at birth. CPK value was normal, 2D echo was also normal. So based on the examination, it was a likely diagnosis of an underlying congenital myopathy, specifically related to it was a collagenopathy basically, which I was thinking about, and causing congenital myopathy, and the associated genes are the Col6A and Col12A genes. So we sent out a whole exome sequencing because both these genes are big genes, so we have to do NGS-based testing rather than a Sanger sequencing. So we sent out a whole exome sequencing, and you can see to my surprise, the result was negative. No pathogenic or likely pathogenic variant was detected. Although this situation we do encounter in our genetic clinics, in spite of a high suspicion of a genetic disorder, the report comes out to be negative. But I was taken by surprise. So I checked the clinical details, and what had happened. Now, this was an international patient. The interpreter had sent out the wrong prescription to the lab. This prescription was that of the ENT specialist who had checked the child for because the child had multiple contractures, so the temporomandibular joint was also involved, and the parents were really concerned, and they had consulted the ENT specialist. So the prescription of the ENT specialist was sent to the lab, which had very few handles for the lab to detect the variant. You can see it just included swallowing and coordination, drooling, does not open mouth or oral cavity, and so on. So you can well imagine how difficult it is to, based on these inputs, how difficult it is to filter the variant. I asked for a reanalysis with my original prescription, and giving the clinical indications of suspected congenital myopathy, likely to be Ulrich or Bethlehem myopathy. And yes, we did get the variant, Col12A1 related, likely to be a compound heterozygous variant, and we could establish the genetic etiology in this patient. Now, when would you order the NGS-based testing? In which situation? So, in all those cases where you are suspecting a disease where a single nucleotide variant, a small sequence variant, is the predominant cause of the disease, or whenever you want to sequence large genes, you want to sequence multiple genes simultaneously, multi-gene panel in genetically heterogeneous disorders like muscular dystrophies, cardiomyopathies, or whenever you're seeing a case which is like undiagnosed or having a blended phenotype. And of course, when you are checking parents, like many times the parents also come up, they are in a consanguineous marriage, they are planning a pregnancy, and they want to check their carriers. We all know that being in a consanguineous marriage, the offspring can be at risk of autosomal recessive disorders, because the parents there is a high chance of parents being the carrier for a significant autosomal recessive condition. So these are the situations where you should order an NGS-based testing, and the yield would be high if you are adhering to these situations. However, NGS is not yet the test for all conditions. There are certain situations where NGS is not helpful, like structural chromosomal abnormalities. You have those inversions um, or large deletions, duplications, chromosomal rearrangements. Then trinucleotide repeat expansion disorders, which I had just mentioned, epigenetic changes, the imprinting disorders. The common examples here are the Prader-Willi syndrome, Angelman syndrome, Silver-Russell, and Beckwith-Wiedemann syndrome, which are common in our clinical setup. So here, the test to be ordered will be MS-MLP-based testing rather than a NGS-based testing. Yes, there are challenges associated with this NGS technology. The complex bioinformatics I have touched upon. Then how to deal with variants of uncertain significance. Then you can always be faced with unsought information or incidental findings, like you have ordered for some other disorder and you've just got to know that there is a pathogenic BRCA2 mutation also. There is a high risk for developing breast cancer or any other hereditary cancer. Carrier status is detected incidentally. And lastly, there is gaps in science exist. We don't have answer for all the disorders. There may be a genetic etiology, but the NGS may not be your testing methodology may not be able to detect that that genetic etiology in the current situation. So now let's come to the next commonly used test called chromosomal microarray. What happens here? You take it's a technology which uses a chip. On this chip, this chip has number of probes, DNA probes fixed on. It's a glass chip, and number of DNA probes are fixed on it at precise coordinates. It's a very high density grid, and you take patient's DNA, which is fluorescently labeled, and you have a controlled DNA, which is fluorescentently labeled in another color. And both these liquid samples are mixed. Of course, there are pre-run process also. This is just a brief and simple explanation of the procedure. And you mix the two DNA, the patient's DNA and the control DNA, and spread it on this chip, which competitively bind with these probes. So since they are fluorescently labeled, they will emit fluorescent signals, which are after the binding, which will be analyzed by the digital imaging software. Now, what does this test does? Chromosomal microarray detects extra, that is duplicated or missing, that is deleted chromosomal segments. The underlying word over here is the chromosomal segment. Till now, I had been talking about the testing methodologies which are looking at the genes as such. Here, it's a bigger area. It's a chromosomal segment which we are looking at. And these duplicated and deleted segments are called as, we club them together, we call them copy number variants or CNVs. So you can detect micro deletion and micro duplications of chromosomal segments, typically which are difficult to see under a microscope if you're doing a karyotype, because a karyotype has a resolution of only 10 kb. Beyond anything less than that will not be picked up by a karyotype. So for looking at these micro del dupes, you have to do a chromosomal microarray. It can also look at the abnormalities of the chromosome number. That means one extra chromosome or one less chromosome, like in Down syndrome, one extra 21, or in Turner syndrome, one less X chromosome. It will also check for unbalanced rearrangements, that is translocations. What does the CMA not detect? It will not detect small changes in sequence of single genes, that is the point mutations. It will not detect tiny duplications and deletions of a DNA segment within a single gene. That means if you have a gene where some few exons are deleted or a single exon is deleted, a CMA will not detect that. A CMA will also not detect a balanced chromosomal rearrangement, like a balanced translocation or an inversion. Now, which are the patients who would benefit from a CMA testing? Patients with autism spectrum disorder. In fact, the ACMG and the American Association of Pediatricians, they recommend chromosomal microarray testing as the first year genetic testing for any patient with unexplained global developmental delay, intellectual disability, or autism spectrum disorder. Or if you're seeing any patient, any child with multiple congenital anomalies, including dysmorphic features, it is useful when other tests have failed to yield a diagnosis like unexplained seizure disorder, growth delay, psychiatric illness, or neuromuscular illness. I have seen many a times it's a tendency to go for fancier test, the NGS-based test, and we tend to overlook or keep aside the simpler tests which are done to look at the chromosomes. Although the technology is coming up where even a NGS based testing will be able to find out it is already doing it. It will be validated more in the future that the same test will be able to check the gene as well as the chromosome. But one can always think of doing a chromosomal microarray testing in situations where the NGS-based testing has failed to give you any answer. I'll just give you a brief introduction about the FISH test, which is acronym for fluorescent in situ hybridization. It is again a targeted test for DNA analysis. Targeted means you need to know what you're looking at. So if you need to know that you're going to look at Williams syndrome, and you cannot write a FISH test. You have to write FISH for Williams, FISH for Downs, FISH for DGeorge, so on. And the other good thing about this test is that it is a rapid molecular test. The turnaround time is around I would say 3 to 4 days. So it is commonly used in a prenatal setting. Apart from this, in transplant pathology and oncology, it is rampantly used. Also, the most commonly used scenarios in a pediatric setup would be for situations like chromosomal aneuploidies, Down syndrome, trisomy 13, 18. Most of the pediatricians may know because they are life-limiting disorders. But other Prader-Willi and Angelman syndrome, which are also microdeletion syndromes, one can order FISH. But I feel that the most useful application in a pediatric or a neonatal setting would be wherever you are dealing with a baby with ambiguous genitalia or a child with a disorder of sexual development, DSD. Because any baby with ambiguous genitalia, it's kind of it is like an emergency situation, societal emergency, I would say, because to reveal the gender of the child becomes the foremost point for the clinician. So how to go about it? The FISH gives you a quick result and a well-validated result. It looks at the sex chromosomes, the X and the Y chromosomes, and you may have your answer about the chromosomal sex of the baby in 3 to 4 days. So this is an algorithm. It is not a watertight algorithm. It is not sacrosanct, but yes, you can follow this flow chart for the best yield of your genetic testing in your practice. So if you had whenever there is a clinical presentation, which is first of all is to have an eye for a genetic disorder. The suspicion is the key to all the diagnosis and workup and management as well. So wherever there is a clinical presentation suggestive of a genetic disorder, which includes which will be based on distinctive clinical features, family history of specific disorder, the results of your ancillary testing, like the biochemistry results, X-rays, complementary assays. And based on that, you see whether a single gene is involved or you are suspecting epigenetic or a triplet repeat disorder. Then I have already enumerated what kind of testing to go for in a single gene situation. If it is conforming to the Sanger sequencing prerequisites, you can go for that. Or NGS-based testing, or a epigenetic disorder, then methylation analysis by MSMLPA, or a triplet repeat disorder, then you go for TP-PCR. If you feel that multiple genes are involved, then of course it makes sense then to go for NGS panel testing, which can be an exome or a genome sequencing. If the disorder you are dealing with, you have multiple non-specific concerns, uh, there are no clear-cut handles. Also, if there is autism and intellectual disability, the first line of testing should be a chromosomal microarray. Exome sequencing or genome sequencing, you can just see if you can do it at the second visit, or many a times if there is an ongoing pregnancy, you may need to do both these testing simultaneously. I would like to conclude with this take-home message. Firstly, one size does not fit all. One genetic test does not take care of all the clinical situations. Application and interpretation of tests is a specialized subject. There is a major role of clinical phenotyping. Uh, Always rely on your clinical acumen. Try to phenotype your patient as finely as possible. Make a close differential diagnosis. Otherwise, ordering any test would be a futile attempt. Especially ordering an NGS test, it would be like garbage in, garbage out. I have already illustrated with one example. If you don't give the clear data, your differentials clearly to the lab, it becomes very difficult for the lab also to give you a concrete result. Liaising with the genetic lab is always helpful in appropriating the testing methodology, and not to forget the pre-test and post-test counseling. It is imperative because it has DNA-based testing has a lot of implications for the family, for the society, and comes with a lot of taboo also. So, I mean, one should spend 5 minutes, 10 minutes for these counseling sessions. I would like to conclude. The day is not far where we will have designer babies. But before that, before we go for that, we should have our ethics in place and our basics, our clinical acumen well intact. Thank you so much. I'll be happy to take questions.
Thank you, Dr. Ranjana, for such a lucid presentation. And you really made things very simple and very clearly demonstrated that how important is it to identify a clear clinical profile and then to select the right test in order to get a positive yield. So I think Dr. Smita has raised hands. I would also invite the chairpersons to join in for the discussion.
Hi, good afternoon. Can I give a question, Dr. Swati?
Yes, please go ahead.
Good evening, Dr. Ranjana. I think we've all had a huge discussion.
Yes.
So very lucid, brilliant. I mean, we still, as clinicians, I speak for myself, don't really understand a lot of times when we're ordering tests. I'll tell you one of the major challenges I face, and we've had this discussion prior also. So yes, you say give the history. So targeted panels are good when you're only looking at what particular set of conditions. Say I'm looking for CH or something. But when I'm dealing with a child of, say, a microgenitalia, and the child is beyond the mini puberty period, so biochemically, I'm not going to get a lot by testing.
Yes.
Right. But the obvious phenotype is there. There is a hypospadiasis, there is a microgenitalia, and there is a significant, by definition, micropenis. A lot of times, you do the biochemical testing, may or may not get something. A lot of times, I get a 5-alpha reductase. Go for the genetic with a clear set of phenotype, the biochemical parameters. You know that there is something in this child because when you get a 0.2 or a 0.3 centimeters of size of a penile length in a child, there has been some abruption in the hormone intrauterine or during the mini puberty. You still don't get a genetic report most of the times, especially with the 5-alpha reductase. It comes back, and this data is there. Published data is also there of 5-alpha reductase. My own data from AIMS that maximum times with the 5-alpha reductase you don't get a genetic defect. So the point is biochemically, the testing is not, say it's not a gold standard, right? Because of the assays, because of the interpretations and the cutoffs. Biochemically, yes, you can make an assumption and start with your treatment, but you cannot prove it for 100%, say it's a 5-alpha. So it's okay for me when I'm treating a child who's pre-pubertal and small, but what is without the genetic basis or a confirmation, it's very difficult for me to prognosticate that when this child hits puberty, is it going to happen or not? So, what is the way forward for genetic testing here when, despite a whole exome, you don't get anything?
Yeah.
So, yes.
I'm sure. Thank you, Dr. Smita. Very relevant question. I'm sure many of the clinicians, they have such questions in their mind. Especially as rightly said, you don't have very supporting biochemical evidence for your underlying disorder, underlying phenotype. In your case, it's a small, let's say it's a micropenis, small phallus. You, your biochemical results are not so there can be two situations. Once your biochemical results are negative, still you're suspecting, and one could be borderline and you want to validate it with a molecular testing. Now, small phallus, it's we know that there are many developmental genes involved with the development of the genitalia, or for that matter, organ development of all humans. So for the development of the phallus as well, there are developmental genes, and unfortunately, many of the genes in the pathway are not they are not there in an obvious way in your commercial testing methodologies. If you or So this could be one reason, that you have the developmental genes are not known in the current situation. Secondly, yes, for 5-alpha reductase also to talk of, what happens is sometimes the mutations, the variations are deep intronic, and they are not covered in a whole exome also. Exome, I've just talked about. Exome is only covering the coding regions, the exomes only of that gene. So if it is till now, we had kept aside, we had just rubbished the intronic regions, the repetitive regions, the non-coding regions. Gradually, as the technology, the science is advancing, we are giving importance to these regions as well. So, I mean, even if you are convinced that this could be 5-alpha reductase, molecular testing may not be able to give you the answer. One reason could be, it could be deep intronic, it could be one of those non-coding regions, and it has not been captured by your technique. And yes, you can go further to explore further. You can go for whole genome sequencing. You can go for optical genome. There are n number of tests available, but to what extent you want to go, and how pressing is the issue. Sometimes in a prenatal situation, yes, it can be, and you may need to go, but everything also, these tests also, they come at a cost. So you have to weigh a balance between how much to give, how much exact result you want to give to your patient, and the patient also, to what extent he or she wants to go and explore the various tests. So it is not only limited to your field, that the molecular testing fails to give you an answer. It does happen. There are lot of causes attributed to it, why it should happen. So one of the most common ones is that it is not covered in it is there deep inside, and we have not reached that region by the sequencing methods.
And there is another thing, Dr. Ranjana, that I would like to highlight, that the technology that you're using for NGS also makes a lot of difference. So so the kind of primers you use, the kind of technology, how many times what was the depth of the panel, or whatever, like exome, whatever you had ordered. So every little thing adds up. The bioinformatics team, the scientist who's analyzing the data. There's so many things. On what platform was it done? What was the pipeline that was used? So so we have it at Max Saket, our genomics lab. So many times, when we really go back and when we really analyze our raw data, that's where we start realizing, okay, fine, the coverage was very much there, but maybe, I mean, if we had done it on, say, a Luna platform, maybe, things would have been, much better. So there are so many other things also. So it's, of course, I mean, deep intronic mutations are very much a reality. And, so with whole exome, you only cover around 1% of the DNA, and rest, all 99% mutations are very much there. And, there's so much which is still so unknown in genetics. Okay. So that is there. And, but apart from that, of course, I mean, I think the technology, with so many labs coming up, everyone offering, all these, whole exome has become like hemoglobin these days, So, but then, no one really undermines the importance of the backend team, the backend technology. No one really kind of, emphasizes that importance. So that might also be the reason. Maybe you can consider asking them for the raw data and ask for reanalysis. Sometimes things do become clear there also. Yeah.
You can, Dr. Smita, you can always get back to the lab. You can give them your genes of interest. This is what I'm looking at. Because they are just bioinformaticians, they can be they have missed, they have to see the coverage, the depth, as Dr. Hemlata has just enumerated. And if there is a fall in the coverage of that gene, fall in the depth of that gene, it makes sense to analyze it by another method, by another orthogonal method, like the any of the PCR based methods.
So follow through on this question. When I want, what this is for my own understanding. So when I send genetic testing for whatever, so there is a set of differentials that I give. So what is the depth of, how much do you guys look into? I mean, I'm sure it is case to case, it varies in person to person. But when there is a DD of say a 2 or 3 like DDs, which is how I usually give that I'm suspecting that this or this. So what is the depth into which you would look into those, even if it's a whole exome? Right? Not a clinical exome. So what is the depth? You will be focusing 100% on most of the common genes prevalent for those conditions, or there is still a chance that you would miss those because for whatever reasons you just enumerated earlier. Right? Even though it's a
The
clinical
thing is,
whole exome, sorry.
so there are two things to this. First of all, that when you make a differential diagnosis, so for that we would actually, so we always talk about HPO terms, okay, human phenotype ontology terms, okay, they are very important for us. So so I always ask the patients that please give us the exact. So suppose you're telling me you're looking for the gene for 5 alpha reductase. I would rather ask you what is the exact phenotype of the patient, like the penile length, and any other associated dysmorphism or anything, any other markers or whatever, so when you keep adding that word mark, so that the softwares are designed in a way, when you keep adding each and every phenotype marker, your differential starts narrowing down to those genes automatically. Okay, so it's not that I have to really kind of enter that. No. So it's like, you enter one phenotype marker, your genes narrow down. Then you enter the other phenotype marker, the genes narrow down further. Okay. So once you go down to that level, then you start seeing that the variations there. Okay. So, but then at the end of it, see, whole exome, even at the best, can only maybe around 30 or maximum maybe 40, not more, So you can't really go into so much depth with whole exome, right? So that is why, we are kind of, we are conducting this webinar to make everyone understand that, there are limitations to every test. Okay. So whole exome, of course, will not be able to kind of, if you ask me that, ma'am, if you can really see the whole of the gene 100 at 100 depth or maybe 500 depth, no. At the end of it, those phenotype markers will keep narrowing down the gene results for you. And but that's it, So I mean, suppose say if whole exome has not read that gene more than 30 times, I can't do anything about it, right? So that's the limitation that you have.
Just
So
wanted
in
to add
spite
a
of
point here. Just
Yeah.
wanted to add a point
Yes,
here. This is with regard to the depth of read. It's very sad, I mean, you guys are still learning. It's very interesting how people who are not from the genetics field, how they ask us about depth of read. I'm glad that, you clarified what you just clarified. What's important to realize is, majority of the people actually ask us a question that, I'm sending you a sample and you're charging me 8,000, say for instance, 15,000 for it. And they want the same read, say at 750K, whereas somebody who's paying only 2,000 will get only 300K. And that's also something which you have to remember. Now, people don't look at the depth of the read. They only look at the price, and they come back to you and tell you, I'll, give me NGS at 2,000 rupees. Come on. I
Yeah,
mean,
yeah.
this is a joke.
Very sad.
So what we
True,
need to
true.
realize is, again, when you're asking for a test from any laboratory, it's extremely important to realize what you're asking for. And most important than that, I know there are commercial interests for a lot of laboratories, but I'm sure most of you would have friends in the laboratories, who would actually guide you correctly. So calling up a friend, as they say, phone a friend and figure out which test should you be ordering for what, that becomes extremely crucial. And that gives you a much better information from what you're wanting to receive from the patient. We face this almost on a daily basis with oncology. And, we've had cases, where somebody's gotten a BRCA done, was negative, and then eventually developed a breast CA. And when the tissue was tested, had the same BRCA mutation as a mother, and the previous test was done at 8,000 rupees and the new test was done at 15,000 rupees. And then she says, why did I not pick it up in the previous one? So, this is a big challenge which needs to be kind of addressed in the genomics laboratories. A lot of people don't even realize about it. You guys are relatively learned, so you guys know it much better than a lot of other people. So I was very happy and, looking at the kind of discussion which was here, because it was very obvious that you know what you guys are dealing with. I just wanted to comment on that. That's it.
Thank you, sir. That was a
Excellent
very
point.
relevant point. And I just wanted to share one very, experience of mine. It is like, we had a family who had recurrent ichthyosis, harlequin ichthyosis in their babies. And I think they had to undergo termination twice or thrice. And we know that when we talk about the yield of genetic testing, if we compare for various disorders, the neurology, the myopathies, and the neuromuscular disorders, we know that the genodermatosis forms a subgroup where the yield is maximum. And we, unfortunately, with such a strong phenotype of harlequin ichthyosis, 3 recurrent babies being affected, we could not find the causative gene in spite of doing all the elaborate testing available. And we have shared this sample with labs abroad for further, which is being done in a research method. And it is just to tell you, just to share with you all that, even with a very high suspicion of an underlying genetic etiology, genetic disorder, you may not get the answer with the widest and the most, highest advanced testing methodology you have used. So, and here again, please do counsel your patients that even if you are spending so many bucks, they may not be able to. I always do that. I mean, this is the yield. It's a practical thing. Otherwise, they can always, like sir had said, that they can always come up that kuch nahi aaya, nothing was found. I had spent so much, and we know what are the limitations of. Although I mean, there are many causes for not getting your answer, but even with a very high suspicion, you may not get. This is a simple fact.
And that is something I always write down in my prescriptions as well, that, the limitations and pros and cons of all the genetic testing has been explained to them, because, and I've always, so you always write that down as well. Apart from explaining, of course, you're living in medical legal, with the surrounded by litigations, and as a geneticist, it's not that we can escape from these litigations. So always mention that there, that the possibility of, missing out or maybe, not being able to identify the mutations despite best possible efforts, with the current technology available worldwide, it's very much a reality, and you should always document that part as well, because patients might just come up, and especially for the prenatal samples, that becomes really tricky, because you keep investigating and eventually, you're not able to offer a prenatal diagnosis, and by that time, the time period for NTP goes away. And then the patient comes back to you and they say, that, see, suppose, if the child, unfortunately, if the child is born with a disorder, one is in a fix that, I was never guided. So keep writing and documenting also. That's so important. I mean, I feel that. So yeah, so and another thing, just to summarize, so I think it's always like, so I remember that when this direct to consumer testing came up, I think it was in late 2000s or maybe 2011 or so by Lumina. So, we were all like, that, it is going to wipe off the clinical genetics and all, but then at the end of it, I still believe that, this phenotyping plays a very major role in the diagnostic yield for your genetic tests. So if one has not really examined the patient properly, and once you have to have a very critical eye, so like many patients, they keep telling me, like yesterday only I was seeing a patient, and the hyperpigmentation and all, and everyone was like, iske na ghar mein sare males kale hain and sari females gori hain. That's how they start attributing, iski shakal to iski dada se milti hai, iski shakal to usse milti hai. But you have to be very objective there, that yes, this is a dysmorphism, it is a dysmorphism, okay? So one has to be very clear, with the phenotype. And that phenotype makes, I think, a lot of difference. The more information you provide to the lab, I think it really goes a long way in the final diagnosis. So, whenever you get a patient clinical examination, always trust the mother. That is something I always say. Trust the mother. She really knows the best. And if she's complaining of something, must listen to her. Never ever, kind of ignore what she's saying in the background even. So, so listen to her, and do a proper thorough head to toe. हमेशा जैसे बोलते हैं ना, एक हाथ सर पे, एक हाथ पैर पे जरूर जाना चाहिए. So that kind of stuff, always do head to toe, undress the child, पूरा head to toe examine करके, and then, you make the pointers, कि ये phenotype है. And then, of course, you kind of broadly classify in your mind whether it is a chromosomal disorder or is it a single gene disorder. And then accordingly, then you try to read about it and see, that which are the common mutations that you identify. Is it a triple repeat disorder? Is it a purely copy number disorder, or is it a deletion disorder? In the chromosomes I'm talking about. Or suppose say in single genes, is it a point mutation disorder like sickle cell, as Dr. Ranjana said, just one mutation out there? Or maybe, you're expecting compound heterozygous or biallelic disorders. So accordingly, you make a broad framework in your mind and order the test accordingly. I think that really helps, I feel. So yeah, that's the only way to increase the diagnostic test, right?
Thank you, Dr. Hemlata. We have a question in the chat box. How to proceed with genetic testing of mental retardation with no obvious physical findings? Same for autism. I think Dr. Ranjana has already covered this. This would be chromosomal microarray.
Yeah.
So if there are no more questions, thank you, Dr. Ranjana, for such a lucid and practical presentation, and our learned chairpersons for the enriching discussions. So we would take your leave today, but next month we will be back with you with another interesting topic in this monthly BLK Telepitch webinar series. Thank you so much.
Thank you.
Thank you
Thank
very
you.
much.
Swati. Thank you, Dr.
Bye.
Rajana, and
Bye.
thank you, Dr. Handoo.